Hello, my name is Kieran and I am an anaesthetic intern at University Hospital Limerick. Today I'm going to give you a case presentation on a delayed presentation of neck injury with maxillofacial trauma. Our patient was a 34-year-old male who presented after a He had a previous left-sided zygomatic fracture confirmed on X-ray and was discharged with pain relief. 2 weeks later, at his outpatient review, he reported new and worsening neck pain, which prompted re-referral to the emergency department. A CT cervical spine revealed a displaced right occipital condyle fracture with atlantoaxial rotation. He was placed in full spinal precautions and managed jointly by maxillofacial and orthopedic teams. This highlights a critical principle. Maxillofacial fractures can coexist with cervical spine injury even after apparently low impact trauma. Studies show between 2 and 12% of patients with facial fractures have associated cervical spine injuries, often at C1, C2, or C6 and C7. A major challenge is that the visible facial injury can draw focus away from potentially life-threatening but less obvious injuries. In this patient, the occipital condyle fracture likely contributed to retropharyngeal hematoma risk, which could threaten the airway. ATLS principle reminded us secure the airway, protect the spine, and consider early imaging when the presentation changes. Learning points and an outcome. So this patient remained neurologically intact and was managed in full spinal precaution for 13 days before being discharged in a mineral collar for follow-up. His facial fracture was repaired under awake fibre optic intubation without complications. The take-home message from this case are: always exclude cervical spine injury in facial trauma, even when the mechanism seems minor. Delayed symptom of onset does not mean the injury is insignificant. And early multidisciplinary involvement between emergency, surgical, and orthopedic teams can prevent devastating outcomes. Thank you very much.